Il lettone no, non c'è.
Galaxy.
Involuntary.
Video out solution.
Video audio.
Digital portion lagi. Sudah sepanjang anda dia berada conference masuk. Jauh jalan berapa foto ya?
Satish bhai, why your video is off?
Ashish bhai, Jagdish bhai, can you hear me?
I can hear you
I
now.
can hear you, but your video is off, Satish bhai. Okay, no, now it is on, but it is not synced. But we can hear. You can start the meeting. It's already past 6. Ashish Bhai, it seems Dr. Satish Pandya, who is in Ahmedabad, might be
Okay.
having some problem. So maybe
Okay.
you may start your screen share and start.
Okay, so I'll be starting off. Thank you, Jagdish Bhai. Thank you to Dr. Satish Bhai, and I welcome all the early morning joinees to the what we'll call as a learning group, which has been going on since so long. I have been fortunate enough to physically give lectures, and this is my first virtual lecture in the Saturday Club group. So I'll start my lecture. This will be on a topic which is very close to
Ashit bhai, sorry to interrupt.
Bolo.
I've just been able to log in. I could not log in earlier because of some problem here. I just wanted to introduce you. I'm sorry I missed the opportunity to introduce you, but I would like to introduce you anyway. Dr. Ashish Sethi is a very well-known consultant gastroenterologist in Baroda, and he has been having a lot of work since more than 2 decades to his credit. He has a lot of international and national publications to his credit, and he's affiliated with several reputed hospitals in Vadodara. So with this brief introduction, I request Dr. Ashish Sethi to start his talk. Over to you, Dr. Ashish Sethi. Thank you.
Saturday Club.
Normally, we all know about metabolic diseases and diabetes and blood pressure, but what I want to start off with all begins with fatty liver. Basically, whatever we see in the metabolic syndrome today, metabolic diseases, is everything related to fatty liver. I would like others to please mute their so that we can have a proper sound. Other people should please mute off their screens. So normally we differentiate between the lifestyle diseases and infective diseases, and but however this COVID has reminded us that it is basically all the comorbidities along with COVID which are responsible for the increase in mortality. So we cannot differentiate between the metabolic disorders and the infective disorders, because the mortality and morbidity of infective disorders is related to the underlying metabolic disease which the patient has or the person has. So the fatty liver itself is a spectrum which starts off with fatty liver, then goes on to NASH, also known as steatohepatitis, and then on to cirrhosis, fibrosis, and in some of the patients has hepatocellular carcinoma. So what I would like to point out that fatty liver is not a disease of the liver, rather it's a multi-system disease where the liver is only one of the system which is affected. Only thing important to note is that everything usually begins with the fatty liver, and the first symptom or the first finding or the first presentation which the patient will come to you is a fatty liver, and if we catch that patient at that stage of fatty liver, we have maybe able to prevent all the metabolic diseases which can occur in the future. So everything begins with a fatty liver. So what we should know is what is this metabolic syndrome and which fatty liver is a part. We should know that metabolic syndrome is defined as a waistline of more than 35 inches in women and 40 inches in men, a triglycerides of more than 150, an HDL level of less than 40 in men and less than 50 in women, elevated sugars, blood pressure. So all this, either 2 out of these 5 criteria are positive, or maybe 3 out of these 5 criteria, then we label the patient as metabolic syndrome. So basically this is the diagnosis, but the patient usually will come to you with a fatty liver. So what are this whole spectrum of metabolic diseases which we see which are associated with the fatty liver? We can see that there are malignancies in there are ischemic heart disease, there's diabetes. So basically the whole gamut of the body systems can be involved by this fatty liver. So the fatty liver is not a thing to be ignored, and it should always be taken very seriously. It's a marker of the future problems the patient is going to have. So we should always try to look for a solution to that fatty liver. So what are the causes of this fatty liver and the cause of the metabolic syndrome? I like to start off the treatment with first knowing a little bit of the physiology or the pathology behind this. Everything begins with the visceral obesity. The patient is obese and has insulin resistance. So there is an interplay between these two. It is not like these are common. So basically, visceral obesity can be the starting point of everything. And we all know that obesity is a state of inflammation. A lot of inflammatory markers are released, mediators are released during obesity. And this release of inflammatory mediators leads to insulin resistance. And that insulin resistance ultimately leads to fatty liver or NASH. On the other hand, visceral obesity itself, because of its increased body weight, leads to sleep apnea, hypertension, hyperuricemia, ischemic heart disease, and others. So you can see from the screen that it's basically visceral obesity and insulin resistance which can together contribute to fatty liver, and then all the other problems associated with this fatty liver. So why does insulin resistance lead to fatty liver? Basically, what happens in insulin resistance is there is excess release of free fatty acids in the blood from the adipocytes, because these adipocytes are insulin dependent and they are not able to respond to insulin, then there is excessive release. Insulin promotes the deposition of fat in the peripheral tissue. So whenever there is insulin dependency, when there is insulin resistance, basically there is a state of insulin deficiency which has been created. So excess fatty acids are released from the adipocytes, and these fatty acids are then taken up by the liver and they lead to NASH. They are converted into VLDLs. These VLDLs are then released into the circulation and that causes atherosclerosis. So you can see what happens when a state of insulin resistance has occurred. There is fatty liver and then there is atherosclerosis. So why should some people develop obesity and some people in obesity develop fatty liver and not others? It all depends on the fat phenotypes. So suppose we eat excess of food, and excess of food is always stored as fat, because fat is the easiest form of energy to be stored. Carbohydrates require a lot of space. Fats can be stored very easily. So fats can be stored in two types. Either it is a Apple type of fat storage, what we know as the upper body obesity, or it's a Pear type of fat storage. This is the Pear type. It's a lower body obesity. So it is the upper body obesity or the Apple phenotype which is dangerous, which is more common in males as compared to females, and it's more common in Indians also. Why the Apple phenotype is more common in Indians? It is because we don't require sub-Q fat. What has happened that we live in a warm climate, and warm climate doesn't require fat for insulation. Secondly, we have been lived in a country where a lot of rivers are there. The soil is quite fertile, so we have abundance of food round the year. Rather in the western climates where they have cold winters and lot of snow, where there can be food deficiencies in the winter months. So we have been genetically modified in the sense that we have less storage of fat in the sub-Q space and more storage of fat in the visceral space. Visceral is the abdominal space around the liver, in the liver, around the pancreas, in the mesentery. So we have a Apple phenotype in India. The Pear phenotype means that the fat is basically stored in the sub-Q space, which happens in the Caucasians. So this is so what has happened is visceral obesity or the Apple phenotype causes a state of chronic inflammation. A lot of inflammatory mediators are released because the fat is stored in the abdomen. These inflammatory mediators are directly released into the portal circulation. So this portal circulation then goes into the liver. So the direct effect of the inflammatory mediators on the liver, inflammatory mediators which are released from the fat in the mesentery. So this ultimately leads to a state of insulin resistance. Insulin resistance, as we all know, increased release of fat happens from the peripheral tissues, and increased uptake of fat occurs in the liver. So basically we get a state of fatty liver. So what are the causes of this visceral adiposity and insulin resistance? I will label as two basic causes of these, both the causes of the fatty liver and the metabolic syndrome is the lack of physical activity and the dysnutrition. I will not call it overnutrition, undernutrition, I'll call it dysnutrition. What is I'll elaborate on these 2 points and then we'll treat these conditions, and then we'll try to treat the fatty liver and then treat the metabolic syndrome. So tackling the visceral obesity, the inflammation along with the visceral obesity, the insulin resistance, we need to increase the physical activity, and then we need to correct the dysnutrition. The medicine part I'll take as the last. So first is the increasing the physical activity. So we all know lack of physical activity has 2 main problems. One is it leads to a state of insulin resistance in the muscle tissues. So the muscles become, if you don't exercise much, your muscles become immune to the action of insulin. That is most important. And secondly, as we all know, if you have less physical activity, you have more calories in and less calories out. And if you have less calories out, you will become obese. So these are the 2 main drawbacks of less physical activity. One is insulin resistance at the level of muscle tissues because not using your muscles, and then obesity. So how do you increase this physical activity? So the first part of treatment of NASH, fatty liver, metabolic syndrome is increasing physical activity. So you can try all forms of physical activity. You can go for resistance training or weight training, which is using of body weight or using of weights to increase your muscle mass. You can go for yoga, which is more of a stretching exercise, but also activates the muscles. The aerobic training, which we call as running, jogging, swimming, walking, cycling, dancing. So all these are aerobic exercises. And fidgeting. Fidgeting is inability to sit at one place. So continuously remaining active throughout the day. So all these things, any form of physical activity you can do. I come to the details in the next few slides. But everything helps even if you don't have weight loss. So the important thing is not to look for weight loss while doing physical activity. Just increasing the physical activity will help you in improving the insulin resistance because your muscles are getting activated. So what happens in exercise? Exercise promotes the use of fat as fuel. So how do you promote the use of fat as fuel? Normally, if we exercise, we can use fat, we can use carbohydrates. But our aim is to promote the use of fat so that we can reduce the fatty liver, the visceral fat, and everything. So the best way of using fat as fuel is to exercise in a heart rate of around 60 to 70% of your maximum heart rate. So if you exercise in the zone of 60 to 70%, you will have ketone body production. So instead of using carbohydrates and using anaerobic metabolism, you will use the fats. So fats will be used up if you exercise in 60 to 70% or what we known as zone 2 exercise. So how do you calculate this 60 to 70% of your maximum heart rate? It's a formula is simple, not very complicated. It's just subtract your age from 220. So 220 minus your age. If your age is 50, that will be 170 is your peak maximum heart rate. So 60 to 70% of 170 will be around 120. So when you exercise, your heart rate should not be in reaching 150s or 160s. If you exercise in the range of 60 to 70% of your heart rate, 80% of the calories which you are getting burned are fat. So you are using the fat. How do you decide that you are working in 60 to 70%? Everyone cannot monitor their heart rate. So if you are working in 60 to 70% of your maximum heart rate, usually you are able to speak short sentences while doing the activity. You are not able to make long conversations, but short sentences like "I'm doing fine," "I'm okay," "It's a beautiful morning," or "Came to maja mach." All these things can be spoken. You cannot carry out a normal conversation. The recommendations are you should at least do 150 minutes of zone 2 exercises a week. That is around 30 minutes, 5 days a week. So this is the recommendations for the routine metabolic health. So these are some of the tables which you can see. You can see that weight loss zone is the zone 1 and zone 2, where the heart rate will be around 133 maximum, and your aim is to improve the metabolic fitness. If you want to go for muscle building, then you go for zone 3, 4, 5. you want to participate in events, then you can go for zone 3, 4, 5. But for a normal layman, exercise in zone 1 and 2 is the best way, where your heart rate doesn't go too much, remains around maximum 70% of your heart rate. And you decided by able to speak small sentences while doing exercise. So this is my my lipid profile, which I had done in 2008, where you can see that the serum cholesterol levels had reached 218 and triglycerides were 190. And since I have been exercising regularly for the last 10 years with, of course, diet control, I can see the cholesterol has dropped down, and the triglycerides have reduced from 190 to 86. So basically, the effect of exercise is more on the metabolic parameters, even without treatment of any medicine. So there's a personal experience to the theory I am telling you. Second is the dysnutrition. Now, dysnutrition can be of two types. We all know excess calorie intake will, of course, be a problem. It leads to obesity. And secondly is the distribution of calories, excess carbohydrate intake as compared to fat and protein intake. So we'll focus on those two things. What happens is, as I have told you, fat is the preferred mode of energy storage in the body, and all the excess calories are stored in the body as fat, and that is leads to visceral obesity, as Indians have low or poor subcutaneous face. So our aim should be to reduce the amount of calories. So target should be 1500 kilocalories per day. So how do you so you can have a rough estimate of how much you eat, but you can have applications for the same. These are like applications are Fat Secret or MyFitnessPal. These are applications which are available in the market on the Google app. So you can download those applications and enter your daily intake, and then you will be able to decide how many of calories. So basically, you have to reduce the amount of calories per day. So this is the first step if you want to reduce the metabolic syndrome or correct the dysnutrition. Some people, how to reduce this low calories? So that itself is a difficult issue, and then we can guide ourselves or guide our patients by two methods. You can do a 5-2 diet, where 2 days of fasting are done, and rest 5 days you can eat normally in a week. So this is a preferred, this is an important method, where 2 days of fasting or very low calorie intake is one of the preferred methods of doing calorie reductions. That is the intermittent fasting. Another is the daily intermittent fasting, where you can eat for only 6 to 8 hours in a day, and 16 hours of the day you can remain fasting, which the Jain community follows. And this is a important method again to reduce the amount of calorie intake. So these two methods you can suggest to yourselves or your patients to reduce the amount of calorie intake. Intermittent fasting method. Second is the correction of the diet pattern, which is happened that our Indians consume too much of carbohydrates. 64% of our diet, as per studies, is composed of carbohydrates. And the problem with carbohydrates, I'll come. Carbohydrates are maximum stimulators of insulin. So if you take carbohydrates, if insulin levels will reach 100% with carbohydrates, they'll be 50% with fats or 25% with proteins. So proteins and fats are very poor stimulators of insulin. So that is one problem with carbohydrates. Second is the satiety. Carbohydrates do not produce as much satiety as proteins and fats. So if you eat sugar and you eat ghee, you will know the difference. Ghee produces so much more satiety as compared to sugar. So fats and proteins produce more satiety. Secondly, carbohydrates are converted easily into triglycerides, and then these triglycerides lead to fatty liver. Secondly, the fructose, the sugar which we eat, which is present in almost all the substances which we get from the market, breads, biscuits, or any bakery items. Fructose or corn syrup is present in all of them. So fructose promotes intestinal dysbiopsies and increases the portal vein inflammatory markers. So this is what happens with carbohydrates. You will have poor satiety, so your food intake will increase. You will have a state of hyperinsulinemia. You will have a state of intestinal inflammation. and this carbohydrates excess will be stored as triglycerides. So these are the problems with the excess of carbohydrate diet. Then I'll come to the problems with hyperinsulinemia leads to. So if you eat excess carbs and your insulin levels are high, what happens with the high insulin levels? The most abnormal thing which can happen with insulin levels increase is the abnormal cell growth. The insulin is a growth factor, so it can lead to abnormal cell growth and can lead to increased risk of cancers. So very important to know that with insulin levels increasing, the risk of cancer increases. Insulin promotes the deposition of fat in the liver, which is NASH. What happens when rapid changes in insulin levels occur? So when you eat, your insulin levels go high, your sugar goes down, and then you feel hunger pangs. So what happens is, if you have rapid changes in insulin level, you lead to hunger pangs and overeating. So this is a problem with carbohydrates. A carbohydrate diet will lead to increased levels of insulin, will lead to decrease in glucose levels, and then a fallen levels of insulin and hunger pangs. So this rapid changes in insulin level with carbohydrates is responsible for hunger pangs and overeating. So how to decrease the carbohydrate intake? So as we all know that increased carbohydrate intake is associated with so many things, and then that is responsible for the fatty liver, the metabolic syndrome, and all its consequences. So how you decrease the carbohydrate intake? So you can increase the protein intake. You will need to eat something. So you don't need just stop the carbohydrates. You have to increase the proteins. The advantage of protein intake, it promotes early satiety. So you feel hungry less, full earlier, you will eat less. It promotes muscle growth, and muscle growth, as we all know, it decreases insulin resistance. The problem with increasing the protein intake is it is difficult in vegetarians. So you will have to look for ways to increase the proteins in the vegetarians. So you should always guide yourself or your patients that how do you increase the protein intake. Second is the fat intake. Fat also helps in early satiety, and we all know that fat promotes ketosis, and which also helps in early satiety. However, increasing the fat intake again becomes difficult in vegetarians. And secondly, increasing the fats may not lead to decrease in calorie intake, because fats are very calorie dense. So it's very difficult to maintain a low calorie diet with excess fat intake. So you have to balance all these things. Then we'll come to that we'll take up that in the questions. And then fat leads to increased LDL levels. So you have some problems with excess fat intake. So it's not like that fat is the panacea of the low carbohydrate diet, but that is one of the ways to go about. So how do I decide? Now, before I started off this lecture in last few weeks or days, there has been an excellent study in the Annals of Internal Medicine published from Denmark, where they have studied a low carbohydrate, high fat diet. High fat is 50 to 60% fats, compared to a high carb, where high carb is 50 to 60% carbs. So as they have compared that, the high fat diet was better than the high carb diet, where the calorie was equal in those. Calories were equal. It improved the metabolic parameters, like it decreased the waist circumference, it decreased the triglycerides, it improved the HDL levels. The sugar levels were better controlled with the high fat diet. So it's obvious, if you decrease the carbs, the sugar levels are bound to go down. So maybe the jury is now shifting towards a high fat diet as compared to a high carbohydrate diet. So we have now to guide the patients to move, especially those who have the metabolic syndrome, the fatty liver, and all the consequences of the metabolic syndrome like diabetes, hypertension, to move to a low carbohydrate diet. So how do I decide a low carbohydrate diet? Usually, basically, you ask the patients to decrease the amount of calories by decreasing the refined sugars. So you have to stop the refined sugars. The refined sugars basically are present in the sugar which you eat, which you put into tea and all the mithais that we eat, and to stop the processed foods like all this baked diet, all the packed items, chips, breads, biscuits, all them contain fructose or fructose corn syrup. So if you can decrease the refined sugars and ask the patient to take the high glycemic index foods like then you can decrease the amount of carbohydrate intake. You have to increase the protein intake of the patient. The protein intake has to be increased by asking him to take more of sprouts and kathor and dal, paneer, all milk-based items. The fat intake you may not change. You may not ask them to reduce the fat intake. So this is how I usually follow. I don't aim to ask more of ghee or tail because that itself can lead to increase LDL levels. I ask them to reduce the carbohydrate intake. Reduction of the carbohydrate intake will and increasing the protein intake will more or less control the food disnutrition which has happened in metabolic syndrome. Then after the exercise, diet, we come to the drugs. Now, what are the drugs available in the treatment of NASH or metabolic syndrome? I don't want to discuss too much on the drugs available in the obesity or metabolic syndrome, but there is so much of commonness between these two. So, the drugs which have been available with us are vitamin E, anti-diabetics like pioglitazone, GLP-1 agonists, and SGL2 inhibitors. The seraglitazole, which is PPR alpha gamma agonist, and obeticholic acid. So I'll touch upon these drugs, and some of part of it will be management of diabetes itself. So there was an excellent trial published around 12 years back in NEJM, where they used pioglitazone and vitamin E even in non-diabetics for control of fatty liver, and they found that use of vitamin E in the dose of 800 milligrams per day, pioglitazone of 30 milligrams per day, decreased the incidence of fatty liver or improved all the parameters of fatty liver. They did not look at the metabolic parameters, but this was the starting point. Like, we have drugs to control the fatty liver and maybe ultimately the metabolic milieu of the whole body. So vitamin E and pioglitazone both were beneficial in controlling. With vitamin E little bit more than pioglitazone. The problem with pioglitazone is the weight gain, the water retention which happens. So pioglitazone is not routinely used in the treatment of fatty liver, and not one of the preferred drugs in the treatment of diabetes also nowadays. Because now we have got better alternatives. But pioglitazone is one of the drugs which decreases the incidence of fatty liver. Then we have the other anti-diabetics, which have recently, last few years or a decade, is the GLP-1 analogs before the SGA2 inhibitors. The GLP-1 analogs, we have semaglutide, liraglutide with us. A new drug is also there. I'll just come to that. What happens with GLP-1 analogs are they don't directly affect the metabolic menu, but they decrease the appetite because they delay the gastric emptying, or centrally actingly they decrease the appetite. So they induce weight loss and they improve the NASH and the metabolic syndrome. So it's a very important step in the treatment of metabolic syndrome, where you directly hit at the diet and then also control the sugar levels. So GLP-1 analogs, the problem with GLP-1 analogs are they're extremely costly. I'll touch upon that in the next slide. Then we have the SGL2 inhibitors, the clozins, kappa and DAPA. The advantage of that, they decrease the hyperglycemia. They excrete the sugar in the urine. So when you decrease the sugars, then you decrease the level of insulin. So you directly affect all the parameters of the metabolic syndrome. So it's an important drug in the treatment of metabolic syndrome nowadays, and treatment of diabetes and the associated problems. You decrease the insulin levels, you decrease the glucose levels. So SGL2 inhibitors again are good in the treatment of the metabolic syndrome. Now we have the GLP analogs. Are tirzepatide is a new GLP analog, which is also a GIP analog. So the disadvantage of these two are the cost and the injections. Now oral semaglutide is also available. I think around 400 rupees per day or 390 rupees per day is the cost. So basically the problem with these two drugs is they can lead to a lot of gastric symptoms, GI side effects. So you can gradually increase the dose. So you have a treatment options available in a patient who is diabetic and who is having NASH and metabolic syndrome. So use either GLP analogs or you can use SGL2 inhibitors. I'll come to that the treatment exact diet part, the drug part. Then we have seraglutazole. Now, seraglutazole is not a purely, it's not a anti-diabetic drug, but basically it improves the insulin sensitivity. It's a alpha gamma agonist. So the main advantage is it's just a pioglitazone addition. It's a pioglitazone plus drug. So pioglitazone is only a PPR alpha agonist. So this is a combination of these two. So improves the insulin sensitivity and decreases the fatty acid release from the peripheral tissues. So pioglitazone is a very important drug in the addition to the treatment of seraglutazole is an important drug in the treatment of metabolic syndrome. So it is available in India as a form of Bilipsa. So it's an important addition to the treatment of NASH and metabolic syndrome. It decreases the hepatic fatty liver because it decreases the insulin levels, decreases the triglyceride levels, improves the glycemic control. However, it doesn't cause change in fibrosis still. So we have seraglutazole again in the one of the drugs in the treatment of the metabolic syndrome. And then we have the obeticholic acid, which is a liver-specific drug, which say just like ursodeoxycholic acid, it is an important drug which decreases the fatty liver and decreases the liver fibrosis. But the problem with obeticholic acid, it causes increased LDL levels and decreased HDL levels. So not a panacea. So it is not too much of in use in the treatment of NASH and the metabolic syndrome. So what will be my take home from this lecture? So any treatment of metabolic syndrome or the fatty liver disease, whenever a patient comes to fatty liver disease, do not ignore that. It will happen, or it is a common, it is 80% of the population has it. Even if the 80% of us are prone to metabolic syndrome. So whenever we get a patient of fatty liver, we should try to intervene at that stage rather than before it goes on to develop a ischemic heart disease, or patient develops hypertension and patient develops hyperuricemia and then develops obesity and sleep apneas and all those things. So we should not ignore fatty liver. We should start off with diet and exercise. So as I mentioned, diet, usually I prefer a low carbohydrate diet. Ask the patient to stop the refined sugars. Ask the patient to stop the processed foods, increase his protein intake, and do not stop ghee. So I don't ask the patient to stop ghee. Now we can have so much of discussion on which type of ghee oil is better, fat is better, saturated, monosaturated, polyunsaturated. So that is a separate discussion issue. Maybe we will take up that in another meeting. But usually I don't ask the patient to stop ghee. Ghee is a very important source of fat and a very important source of probiotics. And I feel saturated fats are better than mono and polyunsaturated fats. So ask the patient to stop his refined sugars. Ask them to stop his processed foods, and then exercise. As I give a prescription of the exercise to the patient. He should exercise at least 45 minutes a day. Try to do running, walking, jogging, swimming, whatever you feel, and do at least 15 minutes of strength exercises a day or yoga a day. Strength means either you do squats or you do push-ups, or you can use dumbbells to use for the upper body. So whatever you are comfortable with, you should try to improve the muscle mass and try to improve the muscle resistance which has happened to insulin. So diet is exercise is important, diet is important. Then if the patient has already developed a metabolic syndrome and has a fatty liver, then a patient is non-diabetic and is non-cirrhotic, then usually I start off after a course of diet and exercise with vitamin E in the dose of 800 milligrams. The disadvantages of vitamin E are or any drug is to be taken very long time. So it ultimately, if the patient corrects his diet and exercises, then his drugs can be stopped. So vitamin D in a dose of 800 milligrams per day. The important is vitamin A should not be used in people beyond 60-65 years of age, because it increases the risk of hemorrhagic strokes and prostate cancer. So in an old patient, we do not use vitamin E. If the patient has already become a cirrhotic and is diabetic, then we can still use vitamin E. But in such cases, maybe obeticholic acid can be used if it's non-diabetic, which is very rare. Non-diabetic metabolic syndrome is not a normal phenomenon. Then the important group which we see nowadays is a diabetic with fatty liver. So what do you do with a diabetic with fatty liver? A diabetic who has fatty liver and doesn't have cirrhosis. So most of our diabetics will have fatty liver. Most of our diabetics will have metabolic syndrome. So how do you treat those patients? So you should try to use the anti-diabetic drugs which are beneficial in the metabolic syndrome. So I prefer that the patient uses SGLT2 inhibitors and GLP-1 analogs. We know the cost of GLP-1 analogs is high, so SGLT2 are a good drugs for the treatment of a diabetes with a metabolic syndrome. And then if the patient has dyslipidemia, which is very common, elevated triglyceride levels, elevated and low HDL levels, then I'll add saroglitazole, that is Bilipsa. So this is how we'll manage a patient who is diabetic with fatty liver, giving them a diet prescription, giving them an exercise prescription, and then trying to use SGLT2 or GLP analogs in the treatment. Of course, metformin is also very good because metformin is one of the basic drugs which is used. So metformin is per se an excellent drug for the treatment of diabetes and for the treatment of metabolic syndrome. So I have not touched about metformin, but metformin is a drug which is used practically in all diabetics, and these are always with the secondary additions, the SGLT2, the GLP-1. Then a diabetic who is cirrhotic, again, SGLT2 inhibitors, GLP-1 analogs, and saroglitazole, they are not contraindicated. So after giving a diet prescription of low carbohydrate diet, increased protein diet, a normal fat diet, asking him to exercise at least 45 minutes a day with aerobics, at least 15 to 20 minutes of day with muscle building. Then if the patient is not responding, then we can go on to the medicines. I thank you all for your kind attention, and I thank the moderators and the participants for tuning on early morning to hear something about a very important and topic which is close to my heart. Thank you. Thank you very much.
Yeah, that was excellent talk, Dr. Sethi. If there are any questions.
Good morning, Ashish bhai.
Good morning.
Can you hear?
I can hear.
Is this fatty liver reversible or it gets arrested with management?
Fatty liver is completely reversible.
Okay.
Because it is not like you have a metabolic syndrome. Nowadays, people can also reverse diabetes. So everything is reversible. Only thing you have to find out the ways or means of doing it. So if you can do proper exercises and proper diet management, then you can reverse your fatty liver. You have a predisposition. Indians will always have a predisposition because we have an increased visceral space for control of fat. So completely reversible. But we can reverse it.
Thank you so much.
Ashish, please stop screen sharing.
Okay.
Yeah. Okay. Is there any method of deciding extent of fibrosis on USG?
There are so many methods, but I usually prefer that any fatty liver is serious. Okay. So if the patient has fatty liver, even if he has no fibrosis or fibrosis, your treatment will remain the same. So that is one. So you can always try to know the degree of damage to the liver by using a fiber scan, which is elastography of the liver, where you can look at the liver hardness. You can have metabolic parameters for the same also. If the platelet count is a little bit on the lower side, if the SGOT SGPT ratio is more than 1, then you can have indirect evidence that the fibrosis has started. So you have metabolic parameters, you have fiber scan and elastography to look at that. But for me, any person who has fatty liver is to be treated, not with medicines. It has to be treated by a diet prescription and by a exercise prescription.
Kiran, you are mute.
Ashish bhai, may I ask a question?
Yes, of course.
So, what is the recommended oil intake per person per month? Is there a minimum and a maximum?
I don't recommend oils as a intake. I would usually recommend ghee as a source of fat. There no recommend. All depends on the body weight. How much is the body weight? I won't exactly able to. But usually your intake of fat should be at least 30 to 40% of your daily intake. If your calories are not going to on a toss, like if you don't consume 2500 2000 calories per day, then at 1500 to 2000 calories, that will come to around 800 to 900 calories per day by fats. So fat being dense, producing 9 calories per gram of fat. So you want to consume 900 kilocalories of fat, that will be 100 grams of fat a day. So 100 grams of fat multiplied by 30 will be able to 3 kgs of fat.
Okay.
So that is the 3 kgs of fat per month should be your intake. But it doesn't mean that you take carbohydrates. That means that you have reduced the amount of carbohydrates and increased the amount of fats. If you go for 30% fat, then you can correspondingly reduce to 2 kgs. So maybe 2 kgs of fat or maximum 3 kgs of fat. So, but overall, your diet should be less in carbohydrates. So this is what answers your question: 2 to 3 kgs of fat a month. But I would prefer ghee.
Thank
you. Dr. Ashish Sethi.
Yes, sir.
Dr. Dalal here.
Yes.
So my question is, if out of 100 patients of fatty liver, how many percentage of patient goes into liver fibrosis, cirrhosis, hepatitis? Is there any study that this percentage of patient goes into cirrhosis of liver?
The percentage is in the sense less, in the sense because we don't know how to diagnose. When the studies were carried out, we did not have fiber scans and all those things. If you really look at the individual person as individual, like if the patient has fatty liver and he has other metabolic parameters abnormal, like he has diabetes or he has hypertension, then the chances of going into cirrhosis are more than 25%. If he has none of the metabolic parameters abnormal, the chances of going into cirrhosis are less than 5%. So if you look at the patient, and if he is an obese patient, he's diabetic patient, he's hypertensive patient, his HDL levels are low, then his chances of going to cirrhosis are more than 25% or maybe reaching 50%. So as individually, you can try to look at a patient. If he has only pure and simple fatty liver, then his chances of going into cirrhosis are less than 5%. But as he grows, as he age grows from 30 years to age of 35, 40, 45, his other metabolic abnormalities start appearing, then his chances of going into cirrhosis increase. So it all depends on individuals. So why some of us will become obese and some of us will not become obese? Why some of us, there's so much of gut microbiome involved in this, because gut microbiome is an important source of metabolism of sugars. So why can some people eat lots of sweets and do not become fat? And why some people become fat with eating a small quantity of feed is related to our genetics also, and maybe the gut microbiome. So if your gut microbiome is strong enough to metabolize the sugars which you are eating, a person will not become fat. So that studies are still not available with us. We have not still reached that stage of understanding. But that is why we cannot say that હું તો બધું જ ખાઉં છું અને મને તો કશું થતું નથી and I don't develop diabetes. That is because you have a better genetic background and a better microbiome profile. So one thing will not fit all. But if the patient has fatty liver and doesn't go on to develop any other parameters of the metabolic syndrome, the chances of him getting cirrhosis are less than 5%.
Another question is that will you wait for biomarkers to increase before you treat the patient, because you don't have any biomarker to follow after treatment?
Usually all fatty livers have to be treated with diet and exercise.
No, I'm not say you will you see the SGPT, SGOT, alkaline phosphatase level before you starting the therapy, because you don't have any biomarker to follow whether the fatty liver disease has decreased or not.
Okay, we don't have proper biomarkers because SGOT, SGPT are not a proper guide to the degree of fatty liver or the degree of liver inflammation that is going on. So we can have multiple parameters to look at. You can look at the SGOT, SGPT, the platelet counts. You can look at so many indexes are available. You can look at the FibroScan score or the elastography score. You can look at the fat on the echogenicity on the sonography, and if you have MRIs, you can look at the fat on the MRIs also. But you have ultimately a biopsy is always there. But my simple is I look at SGOT and SGPT, alkaline phosphatase and GGT. These are the parameters which I see when I treat a patient with medicines, and the patient also looks at those parameters. But we all know that these are not perfect parameters. But whatever it is, if the patient is taking a proper diet and exercise, your fatty liver is bound to improve and drugs will help it. So you may not be too much obsessed with SGOTs and SGPTs, but these are the markers which are available with us.
Reverse is that even the malnutrition patient gets fatty liver.
The problem in malnutrition will be if the diet content is more of carbohydrates. So even if you have a low calorie diet, but the diet is 70-80% carbohydrate, then you will have fatty liver. So it is not like fatty liver is a state of obesity. It is a state of misnutrition. It is a state of deficiency of fats and proteins as compared to the carbohydrate intake. So if your diet consists of 70-80% carbohydrates, that is what we call as lean NASH. What we call as lean NASH or lean diabetics in you. We do patients who not, there will be a genetic background, I don't disagree to that, but some patients will have excess of carbohydrates, and those patients, even if they are not obese, can develop fatty liver.
Dr. Manoj has a question, I think. Dr. Manoj Yadav.
Sir, I already answered.
Okay. Okay. If there are not any more questions, we may end the session. Thank you very much, Dr. Ashish Sethi. It was excellent talk. Beautiful slides, perfectly made. Thank you.
Thank you all the listeners and to the organizers and the moderators. Thank you very much.
Yeah. We end the session. Thank you.
कोण आहे काय काय बैठा म्हणा
Last time. कपाल से ना ना कौन है अच्छा तो लाइटिंग भी खोल रही है ना तो खाली पूरा ब्लॉग नाटिंग दे काम हम कुछ तभी तो हम अगर पॉइंट वाला है Oh my God. આ રીતના તમે કરો તે ખોટું છે રાત્રે તમે વહેલા સુઈ જાઓ વહેલા કરીને મોડા મોડું 11 વાગે તો સુઈ જ જાઓ ભાઈ ઉંમર ઉઠો 8 વાગે એવું નહીં પ્રસાદ તમારી ઉંમર પ્રમાણે હવે તમારે ઊંઘ પૂરતી લેવી જોઈએ
ઓછી લખવાની થાય વાંચો પછી કરવું હોય તો વાંચો જાઓ
એ ભગવાન માણસ તમે હજુ કામ કરો છો કે નહીં નવરા બેસી જાઓ વેરી ગુડ Yes. તમારે બીજો તમારા કેટલા પોઈન્ટ ઓહો તો જો સ્વાપર જ પોઈન્ટ છે
પ્લેન રોજ કરે છે
યા
હા જે પ્લેન કરે છે તે બોનસ માંગે છે મારે માંગે એમાં મારે
તમારો મોબાઈલ કઈ ગયો મારો તમારા કિસ્સામાં તો તમારા કિસ્સામાં તો
નથી ને પછી મૂકો
તમારે
આજે છે ને એમ કરવાનું આવે છે.
એક મિનિટ.
point out. એક બે ને ત્રણ દૂધ
હા તે એ ત્રણ તો હું કરું છું.
કરે છે.
હા ત્રણે ત્રણ કરું છું.
તમારે આ કરવામાં એક દિવસ છે ને 1000 તમારે મારા 620
ના ના હું રોજ ડેલી એ કરું છું.
તમે સર તેમ કર્યા ને જેમાં મારો 1000 લાગે.
ડેલી કરું છું પણ મને કેમ મિલા?
0.619 એક વખત તો જે તારો બિલ મારો લાગી જાય 500,000 તો
1890 પ્રમાણે અત્યારે તો ઓછું છે. 2000 ની ઉપર 300 ની ઉપર જશે.
આજે કેમ
ના હું તો છે રોજ રાત્રે કરું છું. પણ જો કે આખા દિવસમાં પેલું મોબાઈલ લઈને ફરતી નથી.
એક બે દોઢ નાળી પર જોઈએ.
હા તો મને ખબર છે રોજ તમે આ રોજ કામ કરો છો. બોક્સ આવે છે ને હવે રાત્રે જ કરીશ. જમી આજે जंगल जंगल पता चला है चट्टी बहन के फूल खिला है.
Okay. મેહુલ ગયો લાગે છે યાર.
કોણ?
મેહુલ
યજ્ઞ હા ગયો ને.
લાગે છે.
હા
કેનેડા
કેનેડા કેનેડા. પણ એનું તો એ ચાલુ હતું પાદરા એવું એ કરતો કોલેજ.
એટલે ગણાય નહીં માટે.
ને એ તો ના જ કરાય પણ આ તો કે બાય ચાન્સ અને કદાચ કેન્સર થાય રિજેક્શન આવે ફાઇનલ તો ખોટા વર્ષો બગડે ને એટલે ભણતો તે હોય. એને કઈ પેલા શું કે હા કે આ સીઆઈડી નું કરવા પકડમાં એને ત્યાં ત્યાં मैं करूँ फर्स्ट
जय प्रभु। हाँ बोलो। ये है जो हमारे तरफ की जवाबदारी पूरी की है, तो भाषा आई नहीं।
ખખરા સારા છે સારા છે હા મનોજ પટેલ કોણ
ખબર નહીં ક્યાં શું થયું
8,000 મોકલ્યા પેડ
હે
8,000 પેડ એવું
અચ્છા મનોજ
પટેલ મનોજ પટેલ પણ તારે મળવા જાવ છો
મને
ના જાવ છો
કામ બોલે ને જીઓ ને
કામ કશું નહીં જતો હોય તો પછી પડી સેટા જજો ભાઈ
લાવ કઈ બનાવ્યું છે
ના તારે ના પાડે
તો હું કઈ દીધું
આ દીવો પછી સુવાળો
મોકલી દીધી
હા કે
हे प्रभु जाने मारा प्रभु हेलो गुड मॉर्निंग मनोज बोलो पता नहीं देखा मेरी वाइफ ने बोला मनोज पटेल પણ મને तो बराबर है। और रात को मेरा लेट हो गया था, मैं अभी मतलब जाता हूँ। अभी तू कितने बजे निकलने वाला है? नहीं, वो मेन क्या है कि अपने को वहां पे 10:15 बजे पहुंचेंगे ना, तो वहां से फिर सीट काट के उसके वहां रख देंगे खाली सीएनसी वाले को वहां, फिर तू निकल जाना। उसके बाद फिर शाम के उठवा लेंगे, बराबर। और मैंने वो स्टिकर जो ग्रीन कलर थे ना, वो कलर में तो फिट नहीं आती, तो मैंने विनाइल लिया हुआ है उसको दिखाने के लिए। और ग्रीन कलर की जो सीट आती है वो भी थोड़ा सा लिया है, उसको दोनों में दिखा देता हूँ फिर 12-1 बजे कि बोल भाई ये दो में से क्या चाहिए, बराबर ना। आज तू एक काम कर, 10-15 मिनट के बाद ही निकल रहा है ना, आज वो बस उतना बजे के बाद वो दरगाह के पास खड़ा रहना, बराबर। ठीक, कटर ले लेना एक अच्छी वाली, वैसे तो उसके पास ही कटवा लेंगे, उसको ही बोल दे तू मशीन से काट देना भाई। और अपने पास मशीन है क्या, वो राउटर? वो राकेश भाई का यूज कर, नहीं तो फिर वो मैं उसको पूछ लेता हूँ ना, और फिर वो उसका अच्छा है, वो बात वो मैंने बोला ना कुछ करता है। ठीक है, तू निकल और वहां पे पहुंच कर मैं भी सवाल पूछ सकता हूँ, ठीक है।
વાત છે ને હજુ 10-15 મિનિટની.
हाँ बात बोलो।
ના એટલે હું ઉતારું છું એટલે Rosan, બેસી જાઓ. હું મારું લઈ આવું છું. ગરમ ગરમ લઈ આવો.
मन नहीं जो है बस
હું મારા કરું. વાઈ મને.
संभाल भी अर्धो ले जाए
આપણે જમવાનું તો ક્લિયર થયું. મેં અર્જુનની પાસે 250 ગ્રામ ફોરવર્ડ મંગાવ્યા છે તો આ દાદાના છે ને ફોરવર્ડ માં રોઈએ મને યાર હે મેસેજ કરી દીધો દોસ્ત
ચાલો નીકળી જવું છે સંભાળ લેજો હા લાસ્ટ મહોત્સવ તો ભાઈ રાતે બી જોવા જેવું છે દિવસ
શું મને કઈ કીધું
લાસ્ટ મહોત્સવ દિવસ કરતા રાતે જોવા જેવું
લાઇટિંગ ને બધું છે ને
અરે ખબર પડે કે આ બધા આવવાના છે તો તું જાય. जो बदला जा सके उसे बदल, जो बदला ना जा सके उसे स्वीकार, जो स्वीकार ना सके उसे दूर, लेकिन स्वयं को खुश परिवर्तन भी करनी है इसलिए जो पीछे छूट गया उसको शोक मनाने की जगह जो आपके पास है उसका आनंद उठाना सीखो. भगवद्गीता. બીજું પેન્ટ ક્યાં ગયો? બોડીગાર્ડ આવો છે ને? સિલાઈ મારાવો બીજા બી બહુ બીજો પેન્ટ આવો છે ને મારી બેન ગ્રે બધી રાખતા
એમ એટલો જ જોઈએ. આટલો જ જોઈએ. લઈ જાઓ ને હમણાં. રૂમાલ છે? સોય લાવવાની છે આપણે નીકળે આસામથી સોય લેવાની છે. સોયના સોયા બધું લઈ લેવાનું. કારણ કે આ સોય બહુ જ જૂના કાળે બધું હોય
મોજા મારા જે તળિયા છે ખાણા હોય ને જય પ્રભુ.
હા
બરોબર
ઉતારી આપું ને હું એટલો તો ભેજ આવે તો હે એક ક્ષાર બધી જાય આ ઉકેલું છું ને હવે પાછો અઠવાડિયા પાછો થઈ જશે સાંભળ તું અહીંયા
ટોપ મેચ માં એવું લાગે છે
હે
ટોપ મેચ માં એવું લાગે છે આ વખતે
એવું છે કોંગ્રેચ્યુલેશન
કદાચ કારણ કે સેકન્ડ હાઈએસ્ટ વાળાના પણ મારા કરતા ઓછા છે
એવું છે હજુ તો એના ઉપર મુકાશે ને પેલા લઈએ બેટા છે ને જો હા પણ અત્યારે નોટ આઉટ કરે બરોબર અને દાદાનું ફોરવર્ડના રવૈયા બનાવું અને પુલાવ બનાવું હે પપ્પા ગયા બરાબર પુલાવ ખાઈશ તું પુલાવ
250 બરોબર ને
બરાબર લઈ આવું કાલ ઉતારી